Good afternoon, we're so excited to have you here. Welcome to check-in counter for your adventure of knowledge. We're going to show you the comparison of RALOXIFENE versus TAMOXIFEN drug. There is so much to look forward to, but first let us introduce the group. This is the group member. We have Hanis, Namia, Aina, and Chris. This is our agenda. We have a drug profile, patient counseling points, conclusion and recommendation, reference, and lastly, a teamwork.
First profile is a RALOXIFENE is a class of a selective estrogen receptor modulator. It's an oral medication that primarily used in postmenopausal women to prevent and treat osteoporosis, reduce the risk of invasive breast cancer. Next is a TAMOXIFEN. It's a class of selective estrogen receptor modulator also. It's an oral medication and widely used as an hormonal anti-estrogen therapy in the management and prevention of estrogen receptor positive breast cancer.
So, before we get into the mechanisms, what is exactly estrogen and how it is related to bone?
Estrogen is a key female sex hormone that supports sexual and reproductive health. It is mainly produced by the ovaries and in small amount by fat tissues and the gland. So when estrogen level declines, especially after menopause, the bone breakdown speeds up, leading to weaker bone and a higher risk of osteoporosis and fractures. So, the question is, how exactly estrogen affects the bone? So, estrogen is essential for preserving the bone mass and preventing the bone loss. It helps regulate the activity of bone-forming cell, which is the osteoblast, and the bone-absorbing cell, which is the osteoclast. Firstly, it inhibits osteoclast activity, which slows down bone breakdown or resorptions. Second, it promotes the osteoblast survival, which will then support new bone formations. Moving on to the drug profile, the mechanism of action of it, let's begin with RALOXIFENE, a type of SERM, short for selective estrogen receptor modulator. Think of 8 estrogen receptors in the bone like a lock and RALOXIFENE as a key. So depending on the organs, either opens or blocks the lock. In the breast and uterus, RALOXIFENE acts like a fake key that blocks the real one, estrogens. It fits into the lock but doesn't open the door, so estrogen can't get in. It helps prevent breast cancer and avoid stimulating the uterus, lowering cancer risk there too. In the bones, RALOXIFENE acts like a real key. It opens the lock and turns on receptors. This helps strengthen the bones and prevent osteoporosis in postmenopausal women. So, RALOXIFENE is smart. It blocks estrogen where it's harmful and activates it where it helps. That's why it's safer than some other drugs, especially for women after menopause. Fun fact, because it doesn't open the lock in the uterus, RALOXIFENE is less likely to cause uterine cancer compared to the TAMOXIFEN. Now, moving on to TAMOXIFEN, which is also a SERM but it acts differently depending on tissues. Using the same key and lock ideas, TAMOXIFEN sometimes blocks the lock and sometimes open it depending on organs. In the breast, it works like a blocking key. It fits in the receptors and stops estrogen from activating it. That's why it's great for treating and preventing ER plus breast cancer. But in the uterus, TAMOXIFEN is a partial key. It opens the door just a bit, which can stimulate the tissue and may increase the risk of uterine cancer with long-term use. That's why we add a caution sign here. In bone, TAMOXIFEN acts like estrogen and opens the lock fully, helping to protect bone density just like RALOXIFENE. So overall, TAMOXIFEN blocks estrogen in the breast but stimulates it in the uterus and bones. This makes it effective for breast cancer but less selective than RALOXIFENE. So extra tip, TAMOXIFEN is often used in both pre- and postmenopausal women, but because it partially opens the uterine lock, extra care is needed for long-term use. Now that we have looked at the ways the drugs works at the substance level, we will look at the when and why the drug is used. For RALOXIFENE, the therapy indication include it is used to reduce risk and treat invasive breast cancer in postmenopausal women. It prevents and treats osteoporosis by reducing bone loss and the risk of vertebral fractures. It serves as alternative to hormone replacement therapy (HRTs) for bone protection without stimulating the endometrial lining. For the clinical use of it is preferred in postmenopausal women needing bone protection without stimulating breast or uterine tissues. It is also used in osteopenia with strong family history of breast cancer. Warnings: the patient with history of embolism or spectrum they should exercise cautions, which is category D. Last but not least, we will look at the clinical characteristic of RALOXIFENE, in which it is used for women who have had menopause and are susceptible to osteoporotic fractures. And it is also used as the alternative to TAMOXIFEN, which is not recommended for women with breast cancer risk who also have uterine cancer risk. Moving on to TAMOXIFEN, the therapeutic indication include treat the ER plus breast cancer in pre- and postmenopausal women. It is used after surgery for early stage or metastatic breast cancer. It reduces recurrent risk after the CIS. It lowers down breast cancer risk in high-risk groups, and it acts as an alternative for women who can't use RALOXIFEN due to uterine risk. For the clinical use of it used off-label to induce ovulation in women with uninvoluntary infertility, such as because it treats gynecomastia and male breast cancer. It may nature precaution for puberties in girls with McCune Albright syndromes. Warning: it is not suitable for premenopausal women or those with severe ovulatory metabolisms. Moving on, lastly we will look at the clinical characteristic of the tamoxifen, in which it includes the ER plus breast cancer in the premenopausal woman. Next, individual with high genetic background or DCIS, and it is also useful for the male breast cancer patient, which it acts as a treatment of it.
Moving on, we will look at the pharmacokinetic of RALOXIFENE for the AME itself. Firstly, absorption. Due to substantial first-pass metabolism in the intestinal wall and liver, the oral viability of it is poor, which is around 2%. Next, distribution. More than 90% of it is protein-bound to albumin and other plasma protein. Metabolism-wise, it is essentially metabolized in the liver via glucuronidations, not cytochrome P450 like the tamoxifen. Lastly, for the excretion, it is mainly excreted in the feces via the bile, and it have minimal renal excretions. Next, for the tamoxifen, firstly, absorption. Tamoxifen reached the peak level about 5 hours after oral intake and has nearly 100% viability due to slow liver metabolism. Next, distributions, in which highly lipophilic, it is widely distributed in tissues, including liver, uterus, and breast. Protein binding is around 99%. Next, for metabolism, tamoxifen is mainly metabolized in the liver by the CYP enzyme, especially the CYP2, D6, and others, into active forms like endoxifen. Lastly, for the excretion, it is mainly excreted in the feces with some elimination through bile and minute amount via the urine.
Next, I'll be guiding you through dosage and administration for tamoxifen. Tamoxifen is usually taken orally in the form of a tablet. The typical dose for osteoporosis prevention is 20 mg once daily, but this can vary based on your doctor's recommendation. Your doctor may recommend splitting it into 10 mg twice a day. For RALOXIFENE, it is taken orally, usually as a 60 mg tablet once daily. You can take it with or without food, but try to take it at the same time every day to help you remember. It can also be taken together with calcium and vitamin D supplements if recommended by the doctor. Now for the duration of therapy. Tamoxifen is generally used for a long-term period, typically 5 years. In some cases, treatment may continue for up to 10 years. The length of treatment depends on your condition and risk factors. Your doctor may recommend taking tamoxifen for 5 years, then switching to a different hormone therapy for a few more years. And for RALOXIFENE, there is no fixed time limit for how long you can take RALOXIFENE. Many people continue using it for several years. However, it's important to have a treatment review after about 5 years. Your doctor will check if the medicine is still suitable and beneficial for you. For RALOXIFENE, you may experience hot flashes, leg cramps, peripheral edema, which is swelling in the legs, and flu-like symptoms. To manage them, for hot flashes, you can use cooling techniques, avoid triggers, and take non-hormonal options. For leg cramps, you can stay hydrated by drinking water, do some light stretching, and take magnesium under doctor's advice. For peripheral edema, you can elevate your legs and reduce salt intake. And lastly, for flu-like symptoms, do focus on your rest, hydration, and symptom relief. For tamoxifen, you may experience hot flashes, vaginal discharge or dryness, menstrual irregularities, mood swings, nausea, and fatigue. To manage them, you can wear cool clothing, avoid caffeine, and try non-hormonal remedies for hot flashes. And for vaginal issue, use lubricant or vaginal moisturizer. And for others, if symptoms persist or become severe, you must refer back to the doctor immediately. Contraindication and precaution. Tamoxifen should be used carefully in patients at higher risk of blood clots, such as those who with a family history of clots, smoke, or are obese. It should also be used with caution in premenopausal women, those having major surgery or on bed rest. Dose adjustment may be needed in people who metabolize the drug poorly due to CYP260 genetic differences. For RALOXIFENE, it is not recommended for patients with coronary heart disease, stroke risk, thromboembolism, or severe hypertriglyceridemia. Avoid in men, immobilized patients, and for cancer heart disease prevention. Do not combine with systemic estrogen. Use cautiously in patients with mild to moderate kidney impairment.
So let's go into drug-drug interactions or drug-food interactions. For tamoxifen, it can interact with CYP2D6 inhibitors, for example, fluoxetine, paroxetine, and propapion. It can reduce the conversions of tamoxifen to its active metabolite, significantly decreasing its effectiveness. Second, cytotoxic chemotherapy agents. The combination used may increase risk of venous thrombolism. Grapefruit or grapefruit juice may inhibit CYP3A4, altering tamoxifen metabolism, which reducing its effectiveness. And for RALOXIFENE, it can interact with high protein-bound drugs such as diazepam and ibuprofen. It should be used in caution as it may compete for binding sites, potentially altering free concentrations. Next, cholestyramine. It significantly reduces RALOXIFENE absorption, thus decreases its bioavailability. It also can interact with estrogens, in which it can lead to increases in thrombolism risk but reduce RALOXIFENE's protective effect against breast and uterine cancers. In addition, both drugs can interact with anticoagulants, which is warfarin. It can enhance anticoagulant effects by increasing the risk of bleeding. Next, let's go into drug storage and handling. First, store at room temperature, cool and dry place. Do not crush or chew tablets. Protect from excessive light, especially for tamoxifen. No light protection needed for RALOXIFENE. Wear gloves if handling large amount of RALOXIFENE, and most importantly is wash hand before and after handling.